Good morning, and thanks for coming to the thoracic aortic session. I think we have some excellent presentations for you this morning, and I look forward to some good discussion if there's some time at the end. Our first presenter this morning is going to be Frank Arko from Carolinas Medical Center, who's going to tell us about the management of type B aortic dissections. Frank.
I'd like to thank John. I've known John for quite some time. We were fellows together back at Stanford. I think he only invites me down here to so he can beat me in golf. And I've been practicing, John. So I'm going to talk to you about management of entry-tear type B dissections at Carolinas healthcare system. It's a very large system. We actually have a number of dissections that actually get transferred into us from complicated to uncomplicated. And we've actually been able to form a number of different protocols and really get this into a system-wide management of this disease process. So the dissection usually occurs within the medial layer of the aortic wall, as you can see right here. Two most common areas, type A as well as type B, so distal to the left subclavian. Most of what I manage is type B. I work with the cardiac surgeons as well for some hybrid techniques for the type A that extend down. We actually just did one. We actually did five this week. So you can see here, just based on the wall shear stress, the two areas where the dissections are most common. Number of cases are actually quite high, 10 to 15 cases per 100,000 adults per year. That's roughly 10 to 12,000 cases on a yearly basis, most of which, however, are type A dissections, and again, roughly 1/3 are type B dissections. If you take a look at the total acute aortic syndrome, for which we manage, you have the dissections, IMH, penetrating ulcers, and then the thoracoabdominal aneurysm. From Stanford, we typically classify them as type A and type B. The other options are the DeBakey classification, as you can see right here. Type B, again, just distal to the left subclavian. Type A is in the ascending. There are some new classifications that are sort of coming out this dissect from Matt Thompson and Michael Dake, which is also sort of helpful as well, but these are really the classic definitions, as you can see here. So aortic segment, type A, type B, ascending as well as ascending for the type A, type B, distal to the left subclavian, and then really the duration of the clinical onset. So acute, typically within the first 14 days, subacute 14 days, roughly to 3 months, and then chronic greater than 3 months. And then whether it's a complicated dissection or an uncomplicated dissection sort of determines what the management should be, as well as the timing for therapy, if any therapy needs to be done outside of optimum medical therapy. So really, what's complicated? Rupture, malperfusion of any of the visceral vessels or the legs, and then again, rapid thoracic diameter expansion with continued chest pain. You can see here, typically malperfusion is typically due to the false lumen expanding and sort of crushing down the true lumen, especially when the visceral and or renal vessels come directly off the true lumen. It can result in paralysis, renal failure, abdominal pain if the SMA is occluded. If you have a complicated dissection, type B with SMA thrombosis, that typically entails roughly about a 30% mortality. And then finally, pulseless lower extremity. What's the reason really for this malperfusion? Really two types. It can be a dynamic obstruction versus a static obstruction. One is a prolapse septum into the ostium during the cardiac cycle. That's a dynamic obstruction. Oftentimes can be sort of difficult to see on a CT scan. So unless it's gated imaging with MR, or if you actually take a look during a procedure with IVUS, can you really see that dynamic obstruction? And then static obstruction is really the cleavage plane of the dissection extends into the ostium and sort of shuts that off. If you take a look at the uncomplicated type B dissection, there are some patients who are at a little bit higher risk of aortic-related events long-term. If you take a look at the data, these are really the ones that pretend maybe you should treat them a little bit earlier. So if they come in and they have an initial aortic diameter greater than 4 centimeters, the false lumen's greater than 22 millimeters, IMH with a PAU sort of pretends a worse outcome, and then a recurrent or refractory pain or hypertension. If you take a look at those patients who present with pain or refractory pain and hypertension compared to those who have no pain or hypertension on discharge, you can see that there's a significant difference in overall mortality between the two groups. Furthermore, if you take a look at mortality by status of the false lumen, you can see here that those patients with either partial thrombosis or complete thrombosis really have a higher risk of mortality compared to those patients who have a patent false lumen. Furthermore, if you take a look at, this is from Song et al. From Korea, if you take a look at what the overall diameter of the false lumen is at presentation, and you take a look at overall event-free survival, you can see if the false lumen is small, that the event-free survival is actually very low, or actually quite good. If you take a look, if it's greater than 22 millimeters, their overall event-free survival is actually quite poor, and you can see there that up to 9 years it really portends a very bad outcome. Again, so freedom from aortic event, taking a look at dissection-related death, aneurysm formation, as well as a new type A dissection. This is related to medically treated type B aortic dissection, and significant predictors of aortic event with a maximal aortic diameter greater than 4 centimeters at first CT scan, and then IMH with a localized PAU. Again, additional high-risk groups is partial thrombosis of the false lumen, large entry tear, especially up near the left subclavian greater than 10 millimeters, the false lumen greater than 22 millimeters, and then uncontrolled hypertension. Actually sort of interesting to see these patients when they're managed. I tend to manage most of my patients hypertension long-term, but oftentimes they're being seen by a cardiologist. You'll get them every time they're seen, their blood pressure's high, they get added another antihypertensive medication, and it really goes to sort of Jeb's comment earlier. You ask them, they're on 6, 7 antihypertensives, and the question that should be answered or asked is, how many of these hypertensive medications are you actually taking? And they say, well, I take maybe 1 or 2. I usually have to take them every other day because I can't afford them. They go to see the doctor, they just keep getting added more and more antihypertensives, and they're really not taking any of them. And it's really important to control that hypertension. So the goals of medical therapy, which are really the gold standard for the type B aortic dissection, is really to stop the propagation of the dissection and prevent aortic rupture. That's really your anti-impulse therapy with beta blockade, reducing myocardial ischemia, decreasing the left ventricular afterload, decreasing myocardial oxygen consumption, and then avoiding the end organ damage from the complicated dissections. So when you get into actually having to manage these patients, so those patients with a complicated dissection or those patients at high risk, really the goal is to seal off the entry tear. That's the main goal. Attempt to induce false lumen thrombosis and then expand the compressed true lumen. It's sort of interesting, my own management of these patients has really changed over the last 15 years from really sealing off the entry tear to having a bit more extensive coverage, trying to get all the way down to the celiac. One of the trade-offs with that is there's maybe a slight increased risk of spinal cord ischemia, but really in my own practice I haven't seen that. But with this TEVAR for the complicated dissections, you really do expand the true lumen, you alleviate the malperfusion, and you really do promote aortic remodeling. There are some important technical principles. You really want to measure the dissection at zone 2. Most of the time you have to cover the left subclavian. You don't always have to. If I don't, and the tear is a little bit more distal to the left subclavian, I'll land it right at the left subclavian. Sometimes I'll cover the left subclavian 50 to 70%. That keeps the perfusion to the arm and the vertebral and really prevents any sort of complications that can occur from coverage to the left subclavian. That can be either really acute or sort of long-term. I've seen really both of them. I really minimize the amount of graft oversizing in the thoracic aorta. I've really almost now gone more one-to-one sizing. I think that seems to have limited my risk of any sort of retrograde dissections. And then distally landing it and covering as many of the entry tears as possible. I typically go down to about 2 to 3 centimeters above the celiac. I don't do any ballooning during the procedures. I avoid hypertension during the procedures. Oftentimes, if I have to go quite high in the arch, I really like to use rapid ventricular pacing. Here you can see this is just the IVUS of a procedure here. So you can see a relatively large aneurysm up by the left subclavian. That really is going to portend a bad outcome. This is a patient that we would tend to treat, really going up to the left carotid in this case. The management of the left subclavian is really sort of physician independent. If it's an urgent or emergent case, we're pretty fine with just covering it. If it's more of an elective case, we will tend to bypass it or revascularize it. Again, you can see trying to really land it into a nice, healthy zone. We have a dedicated team. We do it as a team of both cardiothoracic surgeons as well as vascular surgeons. We tend to use a lot of IVUS, so we really can, number one, limit the amount of contrast that we have to give. We limit the amount of radiation as well to the patient, as well as to ourselves. Any malperfusion we manage first with coverage of the entry tear with a stent graft, and if there's still malperfusion of one of the visceral or renal vessels, we will then go in there and stent those vessels. These are the cases where they're a bit more complicated, so a lower extremity renal or mesenteric ischemia. Those are ones where we're going to actually go in relatively quickly with TEVAR and then probably stent one of the visceral or renal vessels. These are one of those patients I'll show you here. So you can see the dissection right there. Starts right near the left subclavian, another large entry tear right through this region. A fairly compressed true lumen here. It's a very large false lumen here. Here we cover it. We've got nice expansion of the true lumen. You'll see this, but one of the things that we had on the pre-op CT, and this sort of maintained even post-procedure, was you can see the left kidney is actually quite ischemic and really not getting much flow. You can see the false lumen is actually compressing the true lumen to that left renal. And you can see here on the IVUS, on the actual video, it's a dynamic flap shutting that off. You can see there wasn't much flow going into that kidney. This is post-TEVAR. There still really wasn't much flow, but this is actually a very easy procedure to cannulate that right from the true lumen. And then we can stent that, extend it all the way out into the true lumen, and really maintain patency to that and get that renal to actually recover. If you take a look, what's really the best treatment for these patients, this is the NSTED-XL trial, so management of the uncomplicated type B aortic dissection was the long-term results of randomized investigation of stent grafts. With 7 European centers, a total of 140 subjects, roughly half and half were treated with medical therapy, and then medical therapy plus TEVAR, and then taking a look at all-cause mortality at 5 years. The entry tear was covered for those who underwent TEVAR, and you can see here that overall aortic diameter was fairly stable for those with TEVAR compared to those who got optimum medical therapy, had roughly a 30% increase in size. False lumen thrombosis was achieved in nearly 91% of the patients with TEVAR compared to only 22% of patients with optimum medical therapy. And you can see overall morphologic evidence of remodeling was nearly 80% in those patients who had TEVAR and roughly only 10% in those patients who got optimum medical therapy. If you take a look at overall aortic disease-specific mortality, those patients who had TEVAR had a 12.4% absolute risk reduction and about a 19.1% absolute risk reduction for disease progression compared to those with medical therapy alone. If you took a look at the volume regression of the false lumen at 6 months and at 12 months, you can really see what occurs there, up to 94%. Volume expansion of the true lumen was nearly 100%, and then partial or complete false lumen thrombosis was also very good as well. This is really what you're taking a look for, the aortic remodeling over time. This does take some time. It's not always at 1 month or 6 months, but you really need to follow these patients out for 1 year. It's sort of interesting. Oftentimes you'll get very good remodeling through the thoracic aorta, but it's still important to follow through the visceral segment as well, because you can get some expansion through that area with time. So in conclusion, the NSTED-XL trial demonstrated 70% of type B aortic dissections are uncomplicated. The uncomplicated type B aortic dissection patients are traditionally treated with medical therapy alone, but this really entails about a 30% 5-year mortality rate. NSTED demonstrated elective TEVAR resulted in favorable aortic remodeling and long-term survival. Reinterventions typically were relatively low and clustered in the first year, oftentimes related to either not enough coverage with the first stent graft or reperfusion of the false lumen distally. TEVAR really prevented late expansion and malperfusion and encouraged aortic remodeling. Thank you very much.